Hello everyone, it's me Dr. Ayaz Ahmed. I am working as an aesthetic dermatologist. Today, the topic of my discussion is dermatomyositis. Hopefully, you will learn and subscribe my YouTube channel. Definition: it is an autoimmune disorder affecting skin and skeletal muscle. Bohan and Peter gave classification for dermatomyositis and polymyositis. Greek's criteria is also used additionally. Sondheim classified a myopathic dermatomyositis as a subset of dermatomyositis characterized by a biopsy-confirmed hallmark of cutaneous manifestation of a classic dermatomyositis, occurring for 6 months or longer without clinical evidence of illness such as proximal muscle weakness or there is no any enzyme activity. In hypomyopathic dermatomyositis, investigations are always positive or these investigations are abnormal. Exclusion criteria for myopathic dermatomyositis are: number 1, treatment for immunosuppressive therapy for 2 consecutive months or longer within first 6 months after skin disease, and number 2 exclusion criteria is the drug which is capable of causing dermatomyositis like skin changes, example hydroxyurea. These both are the exclusion criteria for myopathic dermatomyositis. Introduction and general description. It affects skin and muscle, but it also affects lungs, joint, oropharynx, and heart. On one hand, myopathy predominates, and on other hands, the skin disease predominates. Interstitial lung disease are affected irrespective of type involvement. 10-year survival rate is about 90%, usually higher mortality in dermatomyositis have been noticed. Cause of death in dermatomyositis is due to cardiac involvement, which is 15 to 64%, respiratory disease, which is 5 to 36%, and malignancy, which is 10 to 47%. But major here causative agent is the cardiac involvement. Epidemiology. Incidence is variable. It varies from 0.2 to 6.7 per 1 lakh population per year. Prevalence is about 5.1 to 22 per 1 lakh population. Age is usually 50 to 60 years of age. Moreover, it has also been rarely seen in childhood. It is more common in female predominantly affected. Ratio is 2:1 or there may be greater. It is more common in African American than white American people. Associated disease. It is mostly associated with malignancy, for example, adenocarcinoma, CF breast and ovaries, and lung cancer. Here, lung cancer is considered to be a leading malignancy in case of dermatomyositis. Another associated factor is the adult dermatomyositis itself. Increasing age. A study in Singapore and Taiwan shows that nasopharyngeal carcinoma is the commonest association that have been noticed in case of dermatomyositis. Pathophysiology. The pathophysiological features are: number 1, deposition of membrane otic complex and complement C5-9 within capillaries. Another feature is the upregulation of HLA class 1 in a membrane of muscle fibers. Third feature is the capillary dropout with compensatory increase of remaining capillaries. Fourth is the muscle fiber atrophy, and fifth is the infiltration of CD4 plus T cells, macrophage, and plasmacytoid dendritic cells in perivascular and perivesicular area, suggesting humoral mediated microvasculopathy. Associated myositis specific antibodies are: number 1 is the Mi2 TIF1 gamma, MDA5, and USMO activating enzyme. Myositis associated antibodies are anti-52KD, Rho U1, RNP, and PM, SCL, and KU antibodies. tRNA synthase enzyme is targeted by anti-Jo antibody, is a chemotactic factor for lymphocytes and activated macrophage. M1-2 expression is increased, especially in dermatomyositis. Type 1 interferon gene expression is increased in dermatomyositis, in muscles, and in blood. Histopathological features. The histopathological features are lesion-wide reaction with vagular changes in basal layer, appearance of cavitated body, especially in perivascular area, and infiltration of lymphocytes with upper dermal edema and epidermal atrophy, dilation of superficial vessels, and hyperkeratosis, acanthosis, and mild papillomatosis from Gotran's papule have been noticed. In muscles, B cell and CD4 cells are seen in perivascular and perifacial area, and atrophy of muscle fiber have been seen. Deposition of C5 complement and 9 complement in capillary wall are seen. Capillary dropout is a common feature of histopathology. This picture describes the histopathological features of dermatomyositis. You can see lesion-wide reaction in upper basement membrane zone area. Vascular changes are also notable here in this picture. There is the infiltration of lymphocytes and rarely cavitated bodies may be seen. This is the picture showing the skin attack complex and complements C3 and 9 here in case of dermatomyositis. This finding is usually seen in biopsy. Another biopsy finding is the inflammatory dermatomyositis. This inflammatory dermatomyositis is due to increased expression of HLA1 leading to inflammatory dermatomyositis. This is the third biopsy finding in case of dermatomyositis. You can see the muscle atrophy, especially in case of near the perivascular area. Thank you very much. Stay connected and subscribe my YouTube channel.